see what folks do on like Saturday Night Live now. So I do think we are live. Everyone is still muted, and then we'll go ahead and get started right at 6 o'clock on the dot. So I hope that's okay for everyone. So for those of you just joining us, we did just go live. We're going to give folks a couple more minutes to get started, and we will begin at 6 o'clock on the dot. So I'm gonna wait for Tanisha to give us the like final go ahead, but just know I'm here and I wish we had background music. Okay, so got the go ahead. So we'll go ahead and get started. It is 6 o'clock on the dot, so I'm sure we will have other attendees joining us as the conversation progresses. But it is Monday, May 4th, a beautiful Monday here in Virginia, and we are here at another community conversation sponsored by the Friends of Prevention and Richmond Behavioral Health Authority's Community Coalition. So we're joined by three physicians. And before I introduce them, I'll introduce myself. My name is Lauren Winston. I'll be the moderator for tonight. We're here today with these three subject matter experts to specifically talk about COVID-19, how it affects us physiologically, so in our bodies physically, also how it's affected our community in particular, and then of course go into more of the nuances around what we've heard, some of the misperceptions around coronavirus or COVID-19 as it's scientifically referred. So currently in the United States, more than 1 million people have been affected with the virus. About 3 million people worldwide have, over. And now about 70,000 Americans have lost their lives. So today, like I mentioned, we do have three medical experts who are joining us who are going to share more information, not only about the disease itself, but also its impact on our health, our personal health, our public health, so our public health infrastructure, our larger communities, and the short-term and long-term effects of this pandemic on our lives. So first, I'll introduce Dr. John Downs. Dr. Downs is a toxicologist, and he's currently a fellow at VCU Health Systems. So Dr. Downs is going to be speaking first, but before we get into sort of initial chat with him, I'm going to introduce Dr. Chantel Brown. Dr. Brown is a pharmacist at Hope Pharmacy on the Richmond's East End at the 25th Street Marketplace, a beautiful place, if I may say so. And so we're excited to have her here with us. And finally, Dr. Danny Avula. He's the director of both Richmond City and Henrico County Health Districts. So hello to our amazing physicians who are out there working hard. Before it goes live in the chat, we just thank you to each of you for all of the amazing work you're doing. And if you can't hear it, that is my overzealous doorbell. Okay. Now, I'll start with Dr. Downs. Can you tell us a little bit about what is COVID-19? What is the virus and how does it travel and what are the symptoms? And just kind of get into that for us. There's been lots of misconceptions.
Sure, Lauren. I thought that was maybe like a clock chime that you had that sounded pretty cool. It was pretty much on for 6 p.m. So thanks for having me tonight. I really appreciate the opportunity to speak alongside these other colleagues here. It's a little odd for a toxicologist to be involved in this. We're typically dealing with poisons, but by way of introduction, I work predominantly at Virginia Poison Center. So that's the Poison Control Center for Central and Southeast Virginia. And poison control centers have a long history of working with our public health colleagues during times of natural disasters and assisting the public during those times. So one of the things that Virginia Poison Center has done in conjunction with VCU Health is to man an information hotline for the health system there and use our expertise for remaining phone lines 24/7 along that line. Lauren, regards COVID-19 itself, it's a coronavirus, so we've heard that term a lot in the news recently, and that's just a type of virus. This one happens to probably have come from bats. You may have heard that in the news as well. But to simplify things a little bit, it's a respiratory transmitted virus. And although it's not the same as influenza, there's a lot of similarities to that in terms of the way that it spreads and symptoms that someone might have. And so it's kind of reasonable to think about it in terms of it being like influenza, a respiratory illness. It can be a severe respiratory illness. It's primarily spread by respiratory secretions, and that could be particles that are coming out of someone's airway when they're coughing, or even just when they're normally breathing and perspiring as they typically would. We think that it is able to travel around 4 to 6 feet away from people. So if you cough and have some of these viral particles come out, the extent of them going out would be about 4 to 6 feet. So that's why when you hear people suggesting that we stay 6 feet apart from one another. That's the reason for that. We think that if you're more than 6 feet apart, then the likelihood of that those viral particles being able to travel to another person and infect them is much less likely. Hence the 6 feet separation. Regarding symptoms, we think that about 1 in 4 people who are infected may not actually display symptoms, and that's kind of important to know, because those folks can still transfer the virus potentially and transfer the infection to another person, even if they're not overtly having symptoms. So you can't really always easily identify someone who may have COVID-19 and maybe have the potential to actually spread it to another person. Those symptoms, for the most part, would be something akin to what we would expect with influenza or a respiratory illness. So you might get a fever with that. A lot of the folks who've been affected will a cough, perhaps a sore throat, a general sense of not feeling good or fatigue, just not feeling well. And as the disease progresses, people tend to potentially progress to having difficulty with breathing. So most folks will have a relatively mild infection that might be like a bad cold that could probably be managed at home, but around 1 in 5 of folks will have more severe illness and will actually need to be hospitalized and treated inside a hospital for that illness. And again, 1 in 4 folks may be relatively asymptomatic, and even during that time could still be spreading disease. So that's why we've been doing these things to keep ourselves apart from one another and try to stay home, because we just don't know. It's not able to easily identify someone at a distance and know that they have disease. Thanks.
Great. Thank you, Dr. Downs. You brought up some really amazing points, particularly around symptoms, right? So general symptoms, how they can be very similar to the common influenza as we understand it. And also that 1 in 4, maybe even more, folks can be asymptomatic. And so Dr. Brown, that kind of has me thinking about from a pharmacological perspective, what kind of medicines could we use at home for those who don't have access to a test or who might not necessarily meet the criteria right now, the very limited testing criteria? How can folks what can folks have in their homes, right, that could just help them navigate the regular flu, or if it happens to be, coronavirus? And Dr. Brown, I think you're on mute.
I sure was. Yeah, so currently we've seen quite an upkick in over-the-counter medications. We've been counseling on, they've been flying off the shelves. And so what we recommend, especially if you're able to get out or you have your medications or groceries delivered to you, you want to keep your standard Motrin, your standard acetaminophen at home. That's very important. I know there was some information that said ibuprofen originally wasn't the drug of choice, that there was some side effects in dealing with COVID. But after doing more research, they kind of let that alone. And I did my own research. I didn't see anything. Maybe some of the panelists can comment on that. But I'm still an advocate for the Motrin and Tylenol, both, to alternate them every 4 to 6 hours. So if you have that fever, because Tylenol, its original makeup was for fever, it's an antipyretic. The Motrin, it can help alleviate any type of inflammation and muscle aches and pains that you may have. So I would alternate those two every 4 to 6 hours. If you have a sore throat, I would do the good old-fashioned lukewarm water with salt, as well as heat pads that helps with any type of muscle aches. Those are the main things that I would keep. Now, some patients experience some diarrhea. So that's another thing that you possibly could keep at home, having some type of anti-diarrhea like loperamide or Imodium, which will help as well. So just some of the main things to keep in the house at your fingertips at all times. I think that's very important.
Great. Thank you. Thank you for sharing. And also, can you, Dr. Brown or Dr. Downs, before we kind of go to Dr. Avila, can either of you speak to how, have you seen any changes in how folks are accessing medications for their pre-existing conditions? So we know that perhaps Dr. Downs, you can speak initially to how respiratory illnesses like the COVID-19 coronavirus affects folks with pre-existing conditions. And then Dr. Brown, you can perhaps speak to how, if there have been any challenges for folks, as you've seen some of your customers and patients in accessing any of those meds to manage their chronic illness or any pre-existing conditions. So Dr. Downs?
Sure. I spoke before about most people having a relatively mild illness as a result of this infection and being able to manage that at home. But we do know folks that are higher risk for severe illness. Some of those conditions might be folks that are over the age of 65. Certainly, the older folks have had a higher mortality from this disease and have had a much greater likelihood of needing to be hospitalized as a result. Other folks that have a chronic medical conditions, so respiratory diseases like obstructive pulmonary disease, sometimes called COPD, or maybe acquired from a long history of smoking. Folks that are on immunosuppressing medications, so things that knock your immune system down, that will then limit your body's ability to fight off infections. And some of those folks might be people receiving chemotherapeutic drugs for cancer. They might have illnesses like rheumatoid arthritis or lupus, where they need to keep their immune system suppressed in order to control those diseases. So, those folks would be considered at a higher risk for more severe disease, and we would want to watch out and make certain that they have appropriate access to healthcare resources.
And thank you, Dr. Downs. Dr. Brown?
A big one that we've seen, even just today, we have one of my patients, she's looking for her rheumatoid arthritis medication. And what do you know? Hydroxychloroquine is what she needs. And she can't get it. We can't get it because it's stored away for those who need it at higher risk. So that's been the main drug that has flown off of the shelves. At one time, they were talking about azithromycin, but that stayed pretty mainstream. And then the other one that I see, the Pepcid. Pepcid has had quite a run off the shelves as well. So trying to maintain those three medications, they've really been off the shelf and we can't get them. So that's been a problem for us here in the pharmacy.
Thank you, Dr. Brown. And Dr. Abula, I want to transition to you. Like we mentioned before, you are the medical director for Richmond City Health District and Henrico County Health District. So we've seen, a uptick in the deaths related to nursing home positive cases, along with there's been some national news coming out from Richmond about the fact that I think the majority, if not all, of the patients who've died, confirmed cases who've died, have all been people or African Americans here in the city of Richmond. And perhaps you can speak to that later, but right now, and just what things may have contributed to that happening. But for right now, could you speak to what the city is doing and the public health agencies are doing relative to testing? And after you speak to that, if you can kind of explain what is contact tracing. We've heard that sort of term, testing and contact tracing. Testing and contact mapping, those are how you fight the virus. Social distancing and contact tracing and testing. So if you could kind of speak to that, what that sort of means for folks.
Sure. Hey, thanks, Lauren. So I'll just kind of talk a little bit about what the context has been over the last 2 months here in Richmond, Henrico. And our first case in the state of Virginia was back on March 7th. So we've had just under 2 months of watching this pandemic unfold. And at this point, we have just over 400 cases here in the city of Richmond, just under 1,000 cases in Henrico. I think that number was 967 or something when I looked at it earlier today, 964. And really different profiles in terms of people who are losing their lives to COVID-19. In the county of Henrico, we've had 105 people who have died because of COVID-19. And the vast majority of those are residents of nursing homes, assisted living facilities, other types of long-term care facilities. In the city, it's a pretty different picture. There's 16 folks who have lost their lives here in Richmond, none of whom live in long-term care facilities. And so it's 17 as of yesterday. And the demographic profiles, as you were hinting at, in the city, at least 16 out of 17 of the individuals who have passed away are African American, and I think there's a lot of reasons for that, and we can talk about that later in the session, just in terms of how this disease is spread and the impact of underlying conditions and kind of structural inequity and racism and how that impacts health outcomes. But testing has been a big issue for us, right? For us as a locality, as a state, as a nation. You've heard the national media around, we just have started testing way too late. We haven't had the production pipeline for test swab kits. And so those have all been challenges in terms of us figuring out how this disease is impacting us locally. At this point, we are starting to see much more access to testing. I would say, 3 weeks ago, it was still fairly limited. Urgent care centers were doing testing. Some private providers were doing testing. And as each week has gone by, we've seen more and more people adapt testing in their practices. Hospitals have been doing it since the beginning, but VCU and UVA both have really committed their additional test. They've ramped up their hospital-based testing, but they've also committed a certain amount of that testing to support community-based testing, which has really allowed the state lab and the state health department to really significantly expand who we can actually test. Over the last 2 weeks, we have done a series of community-based testing events, primarily focused on the and underinsured residents of our city and county, because we have seen just the inequity of access over the last month and a half of as this has gone on, right? A lot of folks who have insurance and who have a car could go out to one of the urgent care centers and do the drive-through testing. But folks who are uninsured, unless they were extremely sick and potentially hospitalized or lived in a long-term care facility, really didn't have access to that. And so what we've been trying to do over the last couple of weeks is to address that access issue and just to provide opportunities for folks to get tested who are or underinsured. And so we've done a total of 5 testing events so far. We're doing another one tomorrow in Nottingham Green and have a series of testing events that we'll continue to do throughout the month of May. And in parallel to that, we are working with our safety net providers. Things have started to change in terms of access to test kits, and then even the procedures by which you can get tested. So the main way that testing has occurred is that a healthcare provider would basically take this long Q-tip and stick it 3 inches deep in your nose to try to get to that nasopharynx, so the place where your nasal cavity enters into your throat, to get a good respiratory sample to try to see if the virus exists there. The CDC has just come out with new guidance, which would actually allow people to self-swab with just the nasal swab. So instead of having to do that deep nasopharyngeal swab, if they're doing the swab under the guidance of a healthcare provider, they can actually swab themselves and put that swab into viral media. And that whole process actually allows healthcare providers to observe people testing themselves, but not have to get, as Dr. Downs was talking about, not have to get within that 6-foot distance and put themselves at risk. Because one of the big challenges for a lot of healthcare providers to test has been access to personal protective equipment. Now, with self-swabbing and being able to observe from a distance, that same degree of personal protective equipment is no longer needed. And so I really think in these next few weeks, we'll see a significantly increased opportunity for individuals to go get tested at all kinds of healthcare providers, which is good news because the more testing there is, the better sense of where disease is. And then the core public health work, which is really around identifying positive individuals. And so I'm going to transition here to contact tracing, Lauren. Identifying positive individuals and figuring out who they have potentially come into contact with. So many of our residents right now are really following the stay-at-home recommendations pretty well, and so often those contacts are just household contacts. It's the people that you live with, or the neighbors that you're seeing on a regular basis. There are many individuals who still are working, and so our staff follow up with every positive case, do an interview of the time, backdating it to 2 days, 48 hours before your onset of symptoms, and then trying their best based on that patient interview to figure out who else may have been exposed in that time frame. And then going down and tracking those contacts down and then encouraging them to get tested or to actually just quarantine or isolate. So that core work of contact tracing, identifying positives, identifying who the contacts are, and then getting those contacts to stay inside and isolate so that they don't spread the disease to somebody else, is what we have been doing as a local health department. And I think will really be a significant portion of our work in probably the next 6 to 12 months, because as Dr. Brown was saying, there are very limited treatment options at this point, and there won't be a vaccine for at least a year at this point. And so this core work of identifying those contacts and then limiting exposure of other people who potentially may be spreading the disease is going to be one of our best tools to keep outbreaks from happening.
Great. Thank you, Dr. Abula. I have a question, a follow-up question that is from the chat that I think kind of would complement what you just educated us on, which is, and this is from Mika J. Their question was, after testing positive or experiencing symptoms, should you quarantine for 7 days? So with 3 consecutive days without symptoms or meds, or for 14 days total? The message seems to be unclear and changing. So
yeah,
perhaps
well, it certainly
Dr.
changes all the time. But I will try to just clarify that 7 versus 14 day, and then the guidance actually just changed again this weekend. So for the last month, we have been operating under the CDC guidance for clearance, which is if you have tested positive and you have symptoms, then you would be cleared from isolation if you met one of 3 criteria. You had to have at least 72 hours with no fever. You had to have at least 7 days pass from the time of your onset of symptoms. And then you had to have complete resolution of any of your symptoms. And you had to meet all 3 of those. And then at that point, you would considered cleared and could go back to work, or could go back to, you could come off of isolation. Now, over the weekend, that criteria changed. It went from 7 days from the time of onset of symptoms to 10 days. So we've extended the amount of time that you need to stay in isolation from the onset of symptoms. And the reason for that is that we're seeing people continue to shed virus, continue to be contagious for longer periods of time. Now, the 14-day is for people who are quarantining. And let me just step back real quick. So there's a difference between isolation and quarantining. The isolation is for people who actually have symptoms and have been diagnosed with the illness. They are asked to isolate so that they don't spread the disease to somebody else because they are actively contagious. If you were a contact, let's say you were working alongside somebody who tested positive and had spent a couple of days working within 6 feet of them, you don't have a disease yet, but we're asking you to quarantine yourself, to stay at home and to not expose yourself to others. So what you do is the same as isolation, but it's a different category because you haven't developed the disease yet. And the reason that quarantining guidance is 14 days is because 14 days is our best guess at what the incubation period of COVID-19 is, which means from the time that you're potentially exposed, that you've inhaled the virus, to the time that you develop symptoms can be as long as 14 days. So we ask people to quarantine for 14 days to see if they will actually incubate the virus, become infected, and show symptoms. And so if they show symptoms, at that point, we would actually test them. And then if they were negative, then they would basically be cleared. If they were positive, then they would revert back to that other set of criteria. So I know it's a little bit confusing, but that 14-day versus 7 and now 10-day is whether you have the disease and have to meet those 3 criteria versus you've been exposed to the disease and need to quarantine for 14 days. Hopefully that's helpful.
I think that's very helpful. At least that was helpful for me. So Mika, I hope that was also helpful for you. I do kind of want to transition because, Dr. Avula, you sort of spoke to the difference between socially distancing, quarantining, and isolation. And there have been a lot of talks about how so many Americans, like many people around the world, are sort of seemingly growing weary of practicing social isolation. And so there have been several remarks by, national leaders, state leaders about the potential of our state and our federal government and other states opening back up. And there's some recent remarks by the president actually about the injecting disinfectants, using some some new research coming out of the FDA about a new vaccine. But Dr. Downs, if you could speak particularly about perhaps where those remarks may have come from, and if you've seen any uptick in calls to the Poison Control Center about injecting disinfectants. And if you could also just set the record straight about the safety of that.
Absolutely. So first off, just bottom line, it is not safe to drink bleach. It is not safe to inject bleach. It is not safe to drink a disinfectant or any other household cleaner. It is not safe to inject disinfectant or any household cleaner. So all that up front here. Times like these, people are scared. And I said at the beginning of this to the folks that work with me that everything under the sun is going to be attempted in treatment of this disease, and there's going to be some pretty harebrained ideas that come out of that. We see this in public health crises in the past. Folks will try some pseudoscience out there and attempt to treat themselves in ways that they think will either be cheaper or safer or more effective than going to a standard medical facility. And so, periodically, even before any of this started, we still would get people that, might attempt to drink peroxide or something like that, thinking that they would cleanse their body, and unfortunately hurt themselves as a result of that. So poison centers have gotten calls for that, those sort of things for decades. So again, to reiterate, it's not safe to drink bleach. It's not safe to inject bleach. It's not safe to drink disinfectants. It's not safe to inject disinfectants. But if you go down a hole on the internet or a friend of a friend of a friend of a friend, you will find people that come up with this sort of thing, not just for COVID-19, but for all sorts of diseases. And then, unfortunately, us with the poison centers, we deal with the times that those don't go so well. So for bleach specifically, if you drink a good sized dose of that, you're likely to get certainly some stomach upset, some irritation of your esophagus lining here. You probably vomit quite a bit. Large doses can cause somewhat of a chemical burn to your esophagus. Similar things can happen with disinfectants depending upon what type those are. Injecting of bleach is very corrosive to the veins and the arteries themselves. You can also cause a problem called hemolysis, basically when your red cells burst open, your red blood cells just burst. Those are pretty extreme cases, though. So again, we would not want you to do those things. Regards to uptick in calls, even before what's now somewhat the infamous press conference weeks ago now, Poison Centers had actually just released, in conjunction with CDC, a day or two before, a report noting that in comparison to this same first quarter of last year, so between January and March of 2019, in comparison to that, there had been about a 20% uptick in calls to Poison Centers for unintentional exposures to disinfectants and household cleaning products. And that's probably because people are just home more now, and so more likely to have an accidental exposure just being in the house all this time, and because they're trying to keep things clean and be safe and reduce the risk of spreading disease in their own environment. Along those lines, I want to iterate here that mixing of cleaning products at home is not safe either. You can get some pretty dangerous chemicals to result after just mixing some things together from underneath your kitchen cabinet. Mild symptoms might just be some eyes and nose irritation, but in some severe cases, you can actually cause some burning out of your lungs and need to be hospitalized for that. So we do get those calls occasionally too. Virginia Poison Centers has seen about the same thing, a 20 to 30% increase in poison-related or household cleaning product-related calls to our Poison Center over the preceding first 3 months of this year. We're fortunate in that I'm not aware of us getting any calls for folks intentionally taking things like bleach or disinfectants to try to cleanse themselves in any way. Certainly have been reports of that across the country. One other instance, as to tie back into something Dr. Brown said, there was a couple of cases of people using aquarium grade chloroquine, thinking that was going to protect them from COVID-19. And one gentleman at least actually died as a result of that. Chloroquine is a very toxic drug in large doses, and he unfortunately succumbed to that. So I want to remind people too, while I'm here, Poison Control Center number is 1-800-222-1222. Again, that's 1-800-222-1222. They'll get you a free call to a Poison Control Center 24 hours a day, 7 days a week. There's always a nurse or a pharmacist on the line there to take your call and help you with any poison-related questions that you might have. Hope that answers your question.
Yeah, thank you, Dr. Downs. We do have we'll have several actually questions now in the chat. So I'm gonna go to the next one. And perhaps Dr. Avula and Dr. Brown, you can maybe speak to this a bit. And I'll ask both of them because they do have to deal with the relative susceptibility to COVID-19. So, we mentioned before about pre-existing conditions, the higher incidence among African Americans of COVID-19, like being sick and ultimately succumbing. So I'll ask these two questions, and perhaps Dr. Wu and Dr. Brown, you both can speak to it. So the first question is, has there been any research or any results that would shed light onto why children, for the most part, are unaffected by COVID-19? And then the second question by Sharar Sherry states, what is the data on blood type and susceptibility to COVID? Dr. Brown? Dr. Brown, you're muted.
Okay, awesome. Yes. So can y'all hear me okay? Okay, great. All right. So when we look at the children, to my knowledge, it's more so dealing with their ability. They don't really have, their immune systems are pretty healthy for the most part, unless they have some type of autoimmune disease. There are a lot of kids now with diabetes, especially, but usually for the most part, they're fairly healthy. And so that's, to my knowledge, why we haven't seen such a big, at one time they were saying kids would be okay. And we've seen that. We've seen some cases where there have been kids who were affected by the COVID. But for the most part, because their immune systems are generally the healthiest, once you go beyond being an infant, they're pretty, pretty healthy. And so for them to actually come in contact with a person, they could be asymptomatic. And that's why they kind of veer away from the kids and the grandkids being with their grandmothers, just in case, because they could have it or carry it and have no symptoms and be asymptomatic, and where it would have a problem and effect on someone who's older in their 70s and 80s, or someone who has any type of autoimmune disease, or things like heart conditions, heart hypertension, diabetes, all of those that work together, that kind of have a effect on our immune system, especially when it comes to viruses. And so for the most part, kids are fairly healthy. And so they should not, hopefully not, be the main part of this, main carriers or main people affected. They could be carriers. Our kids definitely could be carriers. But hopefully we won't see much of that, which we haven't thus far.
Dr. Avula, would you like?
Yeah, sure. I think Dr. Brown's right. She said it well. Like we don't actually know the why. Clearly, the data shows that kids are less affected by this, and that's good news, because this would be a whole different conversation if kids were having really severe illness. But she's exactly right that even they can be, the reason we canceled schools is because we know that kids are huge vectors of disease. I mean, it's really true in flu as one example, but really any contagious disease. And so the canceling of schools was less about preserving children's health, because children just don't seem to have very severe illness from this, and more about limiting the places where outbreaks can really spin up and then ultimately put our elderly and adult population with underlying conditions. The other question was about blood type, I think. And there has been some initial data that there's a large study in China that had like 2,000 people that showed that people who had a blood type of A were at a higher risk for severe consequences, and that people who had a blood type of O seemed to not have a severe disease. So, I think it's interesting. I don't know that there's a real clear understanding of why that might be. So I would just wait for more studies to confirm that hypothesis. But that's what the early studies are showing.
Great. Thank you. Thank you for that. So we've got another question. Well, actually, two other questions that are related to testing and just the number of positive cases. So this one is from Bonnie W. Governor Northam announced today that there's going to be some relaxation of restrictions during his press conference today that will begin on May 15th. He said that they will expect the numbers of cases to go up. So why should restrictions be eased if officials believe that the number of positive cases may increase? So if you all can speak to, I know that you are not sort of in the political space, right? And you're clinicians, but from a medical perspective, could you maybe speak to the risk and benefits of why or what may happen with these restrictions, or just give us your opinion on what you think easing these restrictions may do? And Dr. Avula, we'll start with you.
All right. Yeah, so here's the deal, is that we're not going to have a fix on this for over a year, maybe longer. And that this virus is going to circulate, and that every time we do any kind of opening up, we're going to see little spikes in disease, So on May 15th, when if we decide to open what we've termed non-essential businesses, our barbers, our salons, our other, small businesses, that is going to lead to more people leaving their house, more people interacting with other people, and that's going to lead to the spread of disease. when we down the road decide to open back up schools, that's going to lead to more virus circulating, and that's going to lead to more people with the disease. Now, the whole point of these very severe community mitigation is what we call this, closing schools, stay at home, no groups of more than 10, all of that. The whole point of all of those severe measures were to allow our hospitals to not be overrun. And that has happened really effectively. Over the last 2 months, our hospitals have actually had significant capacity. Most hospitals are under 50% used. And then another metric that we look at, which is our intensive care unit capacity, the use of ventilators. The use of ventilators in the state of Virginia has hovered around 25%. So all of these things that we as a community have done have actually achieved the desired outcome, which is that our hospitals have plenty of capacity. So this past Friday, hospitals are now allowed to do elective procedures, and dental procedures are back on the table. And each phase of reopening is going to lead to some increase of disease, will likely lead to more people being hospitalized and more people dying. But the hope is that each small phase of reopening will allow for hospitals to be able to treat patients and minimize the impact of COVID-19 as it relates to people dying, right? Because for many individuals, hospital intervention can get them through long enough where their immune system can fight this off and they can actually survive the disease. But if our hospitals are overrun, like we've seen in places like New Orleans and Chicago and New York City, not only will individuals who get COVID-19 not be able to see effective treatment and live, but also people who are still experiencing strokes or heart attacks or other things that require hospital interventions. If our hospital beds are full, they won't be able to get the treatment they need, and we'll see a lot of other people die because of that. And so all of this is kind of a balancing act to make sure that we don't overwhelm the hospitals and allow people to actually have to be treated, but then to, on the other side of that, allow people to have some return to some semblance of normalcy, because we also know that the other side of this, the requirement for people to stay at home and to minimize social interaction, is having its own set of impacts on people, right? It's likely gonna, we may not see the impacts of that for several months, but the depression, the anxiety, domestic violence, child abuse, all of those impacts of our societal disconnection will likely increase because of the social and economic impacts of what we've had to live through the last couple of months.
Great. Thank you, Dr. Bullitt. You made some really great points regarding really the governor particularly implementing some of the social distancing rules and recommendations to mitigate hospitals being overrun. So I know that a lot of folks, I think, have associated social distancing with the eradication, right, of getting rid of COVID-19 in our communities. And so thank you for making that sort of distinction. And it kind of brings us to our next question, which is, what is herd immunity? And, I know that you didn't speak directly to it, but there's this presumption that, like you mentioned, when we go back outside, that the infection rate will rise. And so how do we think through, what does that mean in the long term? So if you could speak to herd immunity, that would be great. And whoever, Dr. Abul?
Yeah, I'm happy to. So, different diseases have different, dynamics based on how contagious they are and how much protection you develop as a result of being exposed to it. Diseases that have vaccines developed to prevent acquiring that disease. So herd immunity looks different for different types of diseases based on some of those factors: how contagious they are, how severe they are, et cetera. Herd immunity with flu, as an example, based on, I don't want to get overly technical, based on the expected number of people who would get infected from one person who has it, is about 80%. You want to see about 80% of the population get vaccinated and develop some kind of immunity to limit the spread of disease within a population. Now, we would love to get, and as Dr. Downs was saying earlier, this does really act in many ways like the flu. And so some of the estimates are looking at about 80% of the population would lead to some degree of herd immunity. There's a lot of big ifs in that. And the biggest being, if you get the disease, are you actually protected from getting the disease again? Because again, we don't have a vaccine, and we won't likely for a year and maybe longer. So, we're still uncertain about if you develop any kind of immunity having gotten over the disease. In fact, there have been some cases reported from China and Korea of people who became symptomatic, tested positive, and then a month later or longer became symptomatic again after having symptom improvement, and then tested positive again. Now, the theory is that maybe there's some reactivation. Maybe the virus hangs around for a long time and can reactivate. But all this to say that we've really only been able to study this for under 4 months at this point, right? The outbreak started in China at the end of December. We didn't really have our first case in the US until the end of January. And so we have a very limited body of information to understand immunity around COVID-19. But theoretically, if you get the disease, you would develop some degree of immunity, and you'd want 80% or so of the population to achieve that immunity. But it's a big if.
Great.
I'd tack on a little bit to that if possible. And just as Dr. Vula was saying, it's a big question right now regards immunity after you have the disease. Is it a persistent immunity? Is there any degree of immunity? And sort of tying in with that, there's been some things in the news about the need for serologic testing to be able to go out and test folks to see if they've been exposed and cleared the disease. And some folks might hear that, oh, if you have an antibody to COVID-19, that you might not be able to get the disease again. And we really don't know if that's true yet or not. So right now, as Dr. Regula said, the primary testing is through nasal washing or swab, but serologic testing is usually from the blood, and we'll look for the antibodies that your body has made against the virus itself. And for some diseases, we can use those antibodies as a surrogate to say you are unlikely to get this disease. So we do that a lot with vaccines like measles and mumps. Test those people, see if they've had an antibody response to that vaccine, and we feel comfortable saying that they're immune to measles or mumps. But we really don't know with COVID-19 yet. There's just not enough information out there, and it seems very difficult to try to extrapolate from prior experience that we've had with other coronaviruses or even influenza. So just want to make sure people are aware of that. If you get an antibody test and it shows that you're positive, well, you may have had the disease and cleared it, but there's no confirmation that you're now immune or that you couldn't. We just don't know right now.
Thank you, Dr. Downs. That actually brings us to our next question in the chat, which is, when will antibody testing be available in Richmond, an RVA, to determine if you have had COVID-19? Or, to your point, Dr. Downs, or may still be at risk of getting it again? So, Dr. Avula, would probably...
Yeah. Sure, I can. If anybody has anything to add, I can just kind of give a current status. I mean, we're right now. I can't remember the latest numbers. Last week it was 4 serology tests. I think it's probably 7 or 8 now that have received FDA authorization. We actually have seen some uptake. Like last week, we started getting positive serology, antigen or antibody testing from local labs who are running this, and so it's happening now. I expect us to see even more of it. And the more testing we do, the more serologic testing we do, and meaning that you're testing for blood and you're looking for the presence of antibodies that your immune system has developed against the virus. Yeah, I expect that we'll see a lot more of that in the months to come, and we'll have a better sense of what it actually means. Because right now, I'm looking at some of the results we have, and you've got the presence of kind of short phase antibodies that develop, and then longer phase antibodies develop. But because we don't know much about immunity, it's hard to really tease out much beyond, yeah, it looks like you've been exposed to this virus. One caveat of that is that there seems to be a lot of cross reactivity, because remember, as Dr. Downs started, this is one mutation of a coronavirus, but there are many other strains of coronavirus, and so there's some cross reactivity. And coronavirus, like the normal coronavirus, is a very mild respiratory illness that we see in kids every single year. So we're still trying to tease out what the value of serologic testing is. But theoretically, being able to do large-scale antigen and antibody testing will help us know just how much of our population has been exposed.
Great. Thank you, Dr. Avula. So you mentioned, a lot around mass testing for both antibodies and antigens. So if you have it or if you have had it. And we mentioned earlier collectively around the disproportionate effect that COVID-19 has had on communities of color, particularly the African-American community here in Richmond especially. And so Dr. Brown has like we mentioned during her introduction, a pharmacy that is located in the east end of Richmond, the Market and 25th Street. So go, if you need a prescription, go check her out. And, but I would like for you, Dr. Brown, to sort of speak to why are African Americans dying disproportionately from the coronavirus, particularly because, like you and Dr. Downs and Dr. Avula mentioned before, in general, coronaviruses are like common, right, among humans, and even though this one is like a novel COVID-19, not like anything we've seen before. But why are we seeing this disproportionate effect on Black communities in particular?
Well, we see every day the different ills that African Americans, Hispanics, that they deal with throughout their time. And so it's the coronavirus and the actual the pandemic and the disproportionate rates. It's just the coronavirus is just highlighting it. This is something that's dealt with constantly, and it's not all based off of African Americans not eating properly, not exercising. Some of it is due to that because of the lack of access, which is why this grocery store is here in a food desert. But some of it is dealing with everyday life, from knowing if, am I going to get the job versus someone who doesn't look like me and we have the same credentials. So those are different stressors that African Americans, minorities have to deal with on a regular basis. And so some of those things are, attributed to it, as well as just not having access to healthy foods, to medications, and living where they live. And so if you think about our housing development that we have here, you talk about 6 feet away, it's kind of hard to do that here. I know in some other states, they've really gone above and beyond with making, you wouldn't even know that their housing facilities are that they are subsidized. They look like normal apartments. But we have a lot of work to do. And the coronavirus is just highlighting the work that needs to be done and the problems that have existed for years. And so, I think my prayer is it will happen, but we don't know. We don't, this is just the tip of the iceberg. And so we'll soon find out.
Dr. Brown, thank you. And before I return to you, I have a question for Dr. Avula and Dr. Downs, and you too, Dr. Brown, if you'd like to contribute. But what is it that you see needs to change? We know that, like you mentioned, the COVID-19 pandemic has essentially unearthed existing disparities. It's shown us what we've already sort of known about access It's those structural inequities that affect how we understand health and disease in the United States. So what do you think needs to happen in the future? What policies or changes need to occur in our cities and states' health system, but also in our country's health system to really not only rebuild trust in those communities who, already might have a level of historical distrust, but also to build a more robust health system so this doesn't happen again? And Dr. Downs, I'd be happy to start with you, and then we go from.
I think from my perspective, on a more global scale or a little higher view, just the emphasis on prevention within our healthcare structure in the United States is overall pretty poor. We could make a lot of inroads there. We have a health system that seems to be set up more on managing disease rather than trying to prevent disease. Once if you have a heart attack, we've got all sorts of things that can be done for helping with that afterwards. But the impetus for trying to prevent those things from happening is a little less so, and it's part of the difficulty with public health and prevention in general. That it's hard to prove a negative. We have to we have a hard time kind of selling ourselves on that, as if the benefits of doing things that might not be seen for another 10 or 15 years. Sometimes in when money is being rationed for resources there, it's difficult for us to sell that. But I think we really have to change our whole perspective here and get back to more of a thought of let's get to the left of the problem. Let's help people address their lifestyle issues. Let's help them get more involved in wellness to prevent these things rather than spending all of our money on the after effects.
Dr. Avula?
Yeah, I mean, so many things need to change. I don't even. We could take this from the health access angle, but I really think fundamentally it's economic inequality, right? Like even when we think about the plight of African Americans that is being unearthed in this COVID-19 outbreak, right? As Dr. Brown was talking about, it is the health disparity of underlying health conditions, which are a result of chronic stress, access to healthcare, but economic inequality is as an undergirding all of that. And then the reality that our African American residents are much more likely to work service-oriented jobs, right? They're the ones who are working, the frontline cashiers in essential businesses, or perhaps as custodians in some of those businesses, or the service level jobs are disproportionately held by minorities. And so that reality, the fact that Black people have higher rates of underlying chronic disease, and they are working service level jobs that put them at greater risk to actually contract the disease, is what's leading to the disparity that COVID-19 is revealing. And so the fix for that is not a quick one, right? It's a long-term generational commitment to addressing economic inequality and providing job opportunities, stable housing, and all of the things that we know contribute to healthier lifestyles and positive health outcomes. So I could talk for hours about that, but I'll stop there.
Thank you, Dr. Avula. And Dr. Brown, anything that you'd like to add just regarding that question in particular?
No, I think that was a point I really, my husband and I would talk about that all the time as it relates to the service industry, like Dr. Avula was mentioning, who's working the registers, who's driving the buses, that it's African Americans, it's minorities, and which makes this exposure, more likely to affect us. And I think with where we need to begin, I know it starts well beyond my days, and just with access and exposure. I know here, the drugs, when this pharmacy came and this grocery store that's here in this food desert, educating and education. That's our main key here. Hope Pharmacy, helping others physically prosper every day. That's our goal. That's our mission. And so coming here in the grocery store and knowing that it's the food, the quality food, the fresh foods versus the canned foods, which is why the prices here on our vegetables and fresh foods are so affordable, is because we're trying to reinforce the importance of healthy eating and having access to it, which in most cases in your inner cities, especially here in Richmond, that doesn't exist. When you go up north, it's more readily available. You'll have your Whole Foods in the inner cities. But here, for example, just in Richmond and Virginia, nothing has been done like this before. And to have access and for it to be for everybody. And so I think it starts there. It starts with access. It starts with exposure. The politics behind it, I can't say. I can't get into it. But, all I can do is my part. And that's why I'm here.
Well, thank you to each of you for doing your critical part. We could not get through this without you, without your care, without your leadership, without your expertise, and your knowledge. So thank you so much for being here tonight and for everything that you do every day for us. And we just celebrate you. So for those of you listening tonight, if you do have any questions regarding testing or want any resources related to COVID-19, you can visit the FOPCRVA.com website. That's FOPCRVA.com. And if you all have any additional questions for our guests, our wonderful guest physicians, please, you can post them on the event website on Facebook, and we will try our best to get back with you. And there will be another event next month. But thank you again, Dr. Downs, Dr. Brown, and Dr. Avula for your time. And I hope you all have a wonderful evening and enjoy this weather. Thank you.
Thanks, Lauren.